I'm Dr. Norman Gaylis. I'm at EULAR in London at the moment. Just finished presenting a very exciting late breaker abstract. So we just presented a study on a very unique therapeutic molecule, something that is known as AB-101. It's an outpatient allogenic natural killer cell therapy that, in combination with rituximab, generates very significant clinical efficacy, with the responses equal to CAR T therapy, which have been shown. But I think the distinct difference is the safety comparisons between CAR T therapy and AB-101 is that AB-101 had almost no significant or did not have any significant adverse events. It's a very, very safe drug, especially for the rheumatology marketplace, as opposed to CAR T. This is a much better choice for the rheumatology space, where you have chronic diseases of longer duration, and with the safety profile being as minimal as it appears to be in the patients that we've studied, I think it's going to have a very significant therapeutic benefit. What we presented today was looking at three very, very difficult conditions that we treat in the rheumatology space. We had very refractory RA patients who had failed 2 or more biologics, including rituximab in 25% of cases. We had patients with Sjogren's disease, very long duration. There is no proven therapy for Sjogren's disease, and we showed outstanding responses in their constitutional, in their serological, and ultimately in their energy and in their dryness. We saw results that I haven't seen in my career. And then finally, in a few patients with scleroderma, which has almost been considered a disease we can treat, we're starting to see clinical responses that are quite remarkable, including losing the fibrosis in their skin. And so I think what we've got is the signal with this study of a very relatively easy treatment for the community rheumatologist. You don't need to be in the hospital. You can be an outpatient, especially those practices such as mine, where we have infusion centers and where we've done right now, I think we've done about 24 patients. It's been easy to fit into the routine of our infusion practice population, and the patients have been very responsive, have tolerated the treatments very well, and my thinking is this is going to be a really, really big plus for those of us who are in the community trying to treat these very resistant diseases, and seeing something that we can utilize safely without really being concerned about especially the CAR T side effects, which makes it very problematic to choose that type of mechanism with our patient population. What we've done over here is we've preempted using these NK cells by effectively reducing the chances of rejection by pre-treating the patients with cyclophosphamide and fludarabine, which are well recognized and well tolerated. And then we give the patients rituximab, because we are going after, almost, if you can visualize, increasing the efficacy of this B-cell monoclonal antibody. We know rituximab has value. We've seen it. But now, in combination with the NK cell, we're able to really see a synergy that allows the monoclonal antibody to be far more effective in B-cell inhibition. In terms of the efficacy, particularly in the RA refractory patients, we saw very, very robust reduction in CDAI, CDAS scores, and in particular the ACR response was very high. The ACR 50 response was in 70% of the patients, and compared to what the literature suggests, where the average response is 25, 27%, this is very, very significant, very rapid, and has not only been durable, but it seems that as time goes on, we actually see a more sustained response.